Hi, this is Dr. David Lewis with McLaren St. Luke's Brain and Spine. If you're watching this video or any of these videos, you've probably seen me in the office, and this is going to be a little bit of a refresher about what we talked about for your particular operation. And now I'd just like to show you some images of a patient who would require a lumbar fusion surgery. So this is an MRI that one of my recent patients has that required a fusion. Again, these images are, it's like we've made cuts vertically through the body and we're looking in at the side. This is the patient's back and the belly's over this way. The feet are toward the floor and this is the spine. And then we also have what's called an axial image, which is like we've made a horizontal cut through the body, and it's the perspective here is as if the patient is laying on their back and we're standing at the feet looking up at the patient. So the back is the bottom of the screen, the belly is the top, and the sides are opposite. The right side of the picture is the patient's left side. This particular patient has pretty bad narrowing of the canal here where we can't really see the nerves with a lot of space around them or fluid around them. And they also have narrowing of an area called the lateral recess, which is where the nerve root starts to branch out at this level. And so this narrowing and compression of the nerves is the main reason that this patient is having symptoms. And then if we look at the other side, this is the level where that trouble is happening. And what you might notice is that the vertebrae are not lined up the same in that area. This is L4 and it's shifted forward quite a bit relative to L5 below it. And that alignment trouble has a lot to do with why the narrowing we were just looking at was happening. For some cases, we just can remove bone and do simple decompression like a laminectomy or a discectomy. But when a patient has this problem, when we go in to remove the parts of the bone and ligaments that are creating the narrowing, we can introduce instability into the spine because the spine is already not staying together as well as it should. And to do the surgery, we're going to remove some of the things that normally help maintain the alignment. And so what we do is not only remove bone and ligament to make that space bigger, we also put a graft into the disc space and some screws and rods into the bone to help keep everything together so that as the patient heals, we don't see worsening of this alignment problem, which would cause more trouble down the road. Now I'm going to show you an intraoperative image of that same patient we were just looking at. And what you can see, it's a little tougher to see. This is an X-ray as opposed to an MRI, so we don't see as much detail. But right here, these are the implants that went into the disc space. Here's L4, here's L5, and then we have screws going into each bone. There are 2 screws in each bone, one on either side. And then all this stuff back here is part of doing the surgery. These are retractors and things that don't stay in the patient afterward. And so this is a little bit what that looks like when everything is all said and done. So for a lumbar fusion surgery, there really are several different ways to do a lumbar fusion. In my practice, what I do most often is a procedure called the posterior lumbar interbody fusion, or PLIF, and mostly that's what we'll talk about here. Like any surgery, there are always risks involved with a PLIF. Anytime we open the skin, we worry about bleeding and infection. Both of those problems are pretty rare in this surgery. The risk of significant bleeding to the point of needing a blood transfusion is very uncommon, unless you're having a multiple level surgery, which again is relatively uncommon in my practice. Most likely we're talking about a 1-level surgery. But even though the need for a transfusion is very unlikely, I always ask permission to be able to do it just in case. The risk of infection is about 1%, and that can be anything from a little skin infection that you just take some extra antibiotic pills for, all the way up to a really big infection that's deep inside the spine and might require a return to the operating room or IV antibiotics for several weeks. It's very rare that we cannot successfully treat an infection. no matter how serious it is, although it can be a problem for quite a while before it gets under control. Thankfully, that kind of infection is not common at all. Anytime I work around the nerves, it's possible there can be injury to the nerves. My number one job is to not do that in surgery, and I work very carefully to prevent that problem. And that's very rare, much less than a 1% chance of anything like that happening. The most common problem that we have in surgeries like this is spinal fluid leak, which typically happens when some of the tissue we're removing from around the nerves is scarred or stuck to the nerves. There's a membrane called the dura that protects the nerves, and if that membrane gets injured, it can cause a leak. A spinal fluid leak is almost always very obvious when it happens in the operating room, and so we know that it's a problem that we need to fix, and we do what we can do to fix it right as it happens. And the majority of the time, whatever we do to fix the problem is successful, and it usually isn't an issue after the fact, other than it delays some getting up and moving after surgery a bit. In some cases, though, the leak can come back and we have to go back to surgery a subsequent time to try a different method to repair the leak. And in rare cases, it can even require multiple attempts and multiple different techniques, but it's very rare that we cannot fix the problem. And it is very uncommon to require multiple procedures like that. With spine surgery, it's always a risk that the procedure won't help fix the problems that we're trying to address. We try to be very selective about choosing patients who have a good chance of recovering with surgery, but unfortunately, it's impossible to predict with 100% accuracy who's going to do well. Certainly, I wouldn't take you to surgery if I knew it wasn't going to help you feel better. And because we're careful like that, the vast majority of people do get improvement of their symptoms, but it's always a risk that might not be the case. When we're doing a fusion surgery, we're putting screws and rods and grafts into the spine to try to get bones to heal together to prevent progressive degenerative change or alignment problems. And one of the risks of that surgery is that the bones won't heal together the way that we want them to. If that happens, a whole range of things can happen as a result of it. In some cases, it's not really a problem other than that we can see on an X-ray or CT scan that the bone hasn't healed together well. But in some cases, if the bone doesn't heal over time, it can cause problems where the grafts or the hardware loosen within the bone or even break, and that can lead to trouble with pain or further degenerative problems, and sometimes we have to go back to surgery to fix those problems. Thankfully, that's relatively rare, but it does happen on occasion. Those are kind of the major things we worry about particular to that surgery. After surgery from a lumbar fusion, most patients stay in the hospital for a couple of nights. So if your surgery was, say, on a Monday, you would most likely go home on a Wednesday. Depending on how much difficulty you have with pain and getting around, on some occasions, people will go to a nursing facility for some intense therapy before they go home. That's more common in our older patients or in patients who are having surgery at multiple levels or patients who have really limited mobility because of their pain before surgery. But for most folks, going home on the second day is what we expect. At the conclusion of the surgery, we leave a drain behind that helps evacuate any fluid from the surgical site. It's basically just a little tube that comes out through the skin, and that needs to be removed before you leave the hospital. And for some people, that's the thing that keeps them in the hospital the longest. Again, 2 or 3 days is the usual experience. After you're home, and even before you go home, we want you up and moving right away. Getting up and walking, moving your legs, sitting up, changing positions. This is all uncomfortable at first, but the more you do it, the more quickly things start to feel better. And so we really encourage people to get up and move regularly after surgery. The exception to that is if you have a spinal fluid leak, like I discussed a little earlier. When that happens, we generally keep you flat in bed for the first couple of days to try to give the area where we've made our repair a chance to heal up a little bit before you stress it by getting up and moving. But unless you've had a fluid leak, we really push you to get up and going, because that's what helps you feel better. Once you're home, you can really do a lot of things. I try to keep it simple in terms of what you can't do, and I try to boil it down to two main rules. One is I don't want you to lift anything that you need to strain to lift, which we usually say 10 or 15 pound limit. And I don't want you to do things that require a lot of bending or twisting your back. So things like emptying the washer or dryer or a dishwasher, or raking in the yard or vacuuming. Those kinds of things, even though they may not seem that taxing, really require a lot of bending and twisting your back, and we want you to hold off on that at first. But there's no limit to how much you can walk. It's safe to go up and down stairs. It's safe to go out and about if you feel up to it. I ask you not to drive while you're using prescription pain medication, but once you're off of that, if you're moving well and you're confident that you can control your car safely, it's okay to drive. And that's different for every patient. Sometimes it's a few days, sometimes it's a couple weeks. Typically I would plan to see you about 2 weeks after surgery for your first post-operative visit. And then a month or so after that, or 6 weeks after surgery, to check in and see how things are going. If you're doing well, there's a good chance that'll be the last scheduled appointment in the office. If you're having difficulty or something's not coming around as quickly as we'd like, we'll certainly keep checking in with you until we're all satisfied that we're moving in the right direction. And even if we get beyond when we've planned appointments, I'm always happy to hear from you or see you in the office. All you need to do is call us, and we'll be more than happy to get you in and hear your concerns and see what we can do to help. So I hope that is a good refresher of what we discussed about lumbar fusion surgery. If you've seen me in the office, that probably sounds very familiar. If you're just watching these online and you'd like to have another opinion, please feel free to contact our office at McLaren St. Luke's Brain and Spine, and we'd be happy to schedule a consultation with you.